Excellent. So I'm hoping it's just loading. Okay, so hopefully you've just got a PowerPoint screen. So firstly, thank you very much for spending a Saturday evening listening to my presentation. It's nice that we have some other Australians. So my presentation is about my PhD research, and I'm in Australia, and the research will be conducted in Australia. So this is part of what presentation I did for confirmation of my candidature, and it's about 20 minutes long. I'll try and keep it moving. I suspect that you may know a lot of what I'm going to talk about, but a lot of it is really important for me just to provide context. So, as I said, thank you for devoting this time to my presentation, and I acknowledge the Walbunja people of the Yeon Nation as the traditional owners of the land I'm presenting from today. I pay my respects to their continuing culture and the contribution they make to this region. So let me just move to the next slide. So this is to thank Amber, Alexandra and Veronica for assisting with me doing the presentation. Finally, we're there. So starting with the problem, and as I said, a lot of this you'll be very aware of, but hopefully it's good background. So the Productivity Commission in Australia has detailed the difficulty many Australians have in accessing general practitioner or GP services. Seeing your own GP can take some negotiation and juggling. GPs have more patience than time allows. They have more, they move practices, and some practices close. And this is increasing the difficulty of access throughout Australia. Rural communities have it a bit tougher. Some towns have a GP and some towns don't. Specialist services may be available in larger towns. People in smaller towns may have visiting specialists, or they may need to travel to larger centres for these services. The Australian Bureau of Statistics report called Patient Experiences, released late last year, highlights challenges for people in rural communities. Rural people wait longer for an appointment with their GP, or in fact, any GP. Because of this wait, they're more likely to present at the hospital emergency department. They find themselves seeing their GP for urgent care rather than routine or preventative care. So the broad problem is a lack of GP consultations available in rural communities. So let's look at what the context for this problem is. A number of publications describe elements of the context. The supply of GPs across Australia is declining, and there are fewer medical graduates indicating preference for the general practice, and fewer doctors are entering the Australian General Practice Training Program. And GPs are increasingly reducing their hours or stopping practice. Again, rural communities find it harder, according to the 2023 Health of the Nation report. 46% of GPs are unwilling to work outside the metropolitan area. And despite efforts, the number of GPs in training in rural areas is remaining constant rather than rising. Patient presentations are increasing in complexity due to the factors such as the ageing population and the increasing prevalence of chronic disease. The number of consultations being sought reflects patients' difficulty accessing specialist and tertiary care. So just before moving on to what we know and don't know, I'd like to just talk about what rural means. In Australia, the modified Monash model is commonly used as classifying the level of rurality. Areas are classified according to the town size and geographical remoteness. The MM model applies to all of Australia. But let's look at the picture for New South Wales to give an understanding of how it works. I've indicated the rural health regions in the small red box. These health regions spread from the coast, over the ranges and to the inner west. You will see that the tan MM3 and the purple MM4 pockets are scattered throughout the green MM5s. So these MMs 3, 4 and 5 are the rural areas that I'm looking at. So what is the gap between what we know and what we don't know in relation to the lack of GP consultations available in rural communities? Researchers, communities and universities are aware of the issues, and governments too are aware of the issues, and there are currently many strategies. Unfortunately, there is no one solution to balancing the GP supply-demand curve. The economic, socio-cultural and technological world we live in changes constantly. This creates a need for continuous monitoring and the balancing act, constant reflection on our activities and considered implementation of strategies. So what we do know? What we do know is that the health workforce capacity and capability in rural areas is of international interest. This reference is the 2021 World Health Organization's guideline on health workforce development, attraction, recruitment, and retention in rural and remote areas. The development of this document is important for illustrating its application to the Australian context, so I'll walk you through the history. In 2008, Henderson researched the incentives for retaining and motivating healthcare workers in the Pacific and Asian countries. Part of the resulting paper was this model of factors affecting health worker motivation and retention. Not all of these elements were applicable to high-income countries where there are private practices, different health systems, and higher socioeconomic conditions, but it was a good starting point. The WHO seemed to agree with Henderson's concept, and in 2010 developed the model further to be applicable to all countries where the distribution of healthcare workers was an issue. Further refinement of the elements descriptors was presented in the 2021 WHO report labelled Factors Related to Decisions to Relocate to, Stay in and Leave a Rural Area. WHO in 2010 also highlighted that each of these factors is very complex as they relate to personal aspects, the health system characteristics, and the overall social, economic, and political environment of the country. They also indicate that the interplay between the factors is complex and strongly influenced by the underlying motivations, be they economic, social, cultural, or religious. These 2021 WHO factors are a valuable foundation for my research. So we also know about workforce distribution in Australia. The Australian Government's National Medical Workforce Strategy 2021 to 2023 provides some sobering facts. The chart on the left-hand side is the number of full-time equivalent GPs per 1,000 population by the MM rating that I described earlier. The right-hand side chart is the corresponding information for specialists. Together, these charts show the distribution of Australia's GP and specialist workforce. The chart on the right shows the number of specialists tends to decrease with remoteness, whereas the left-hand side chart shows GPs increase with remoteness up to MM4. So what happens at MM4? What happens is that with the reduction of specialists, the GP's role changes. Their responsibilities are broader. Their work includes public health, hospital, and emergency work. We know that MM4 is really where distribution becomes maldistribution. Now let's have a look at what we don't know. So what we don't know is the full range of reasons, factors, issues and influences on a GP's choice of rural practice. To get an understanding of what we don't know, I'm turning to the WHO again. In their 2010 report pictured here, recommended a range of principles for consideration by countries when they're formulating their national rural retention strategies. This slide highlights a key point, that is the WHO recommendation for an in-depth understanding of health workforce. From the underlined list, we know that there is comprehensive reporting on situation analysis, and there is research on many of the factors of influence. Sorry, I've just lost my place. Here we go. The last item on the list is about labour market analysis. This type of analysis may include a number of elements, and from this list, the gap in our knowledge is this reference in green to occupations and positions. When a GP chooses rural practice as an occupation, their considerations include the clinical work, and from the practical business side, they look at the characteristics of the job. The clinical activities of a rural GP are well documented. In fact, universities and GP colleges ensure training for these skills. Job characteristics is an area we don't know a lot about, and yet it is a really important part of choosing rural practice. And I'm just walking you through now about what job characteristics are. Think of job characteristics as the non-clinical side or the administrative business side of a job. So, work agreements, these are the type of employment relationships the GP has with the business entity. Agreement options include being an employee, becoming a practice business owner, or maintaining a contractor status by paying a fee for the business service. Work responsibilities, this refers to the activities for which a GP is responsible. These fall into two separate but potentially overlapping categories: in practice and out of practice. These responsibilities tend to be dynamic, changing with the ebb and flow of the practice, the community, and the influences of technology, legislation changes, and patient perception of needs. Interestingly, many of these responsibilities are tacit expectations that the GP only becomes aware of once they've actually started in the position. Consider the on-call and after-hours responsibilities. These may be for a general practice, the hospital, or both. For example, hospital responsibilities for obstetrics on call may make for a night with no sleep. So what happens to the practice responsibilities the next day? Different responsibilities and likely to be different agreements. One agreement with the practice and one agreement for the hospital. So then the last one, work rewards. Work rewards describes the modes of payment for the responsibilities. They may be direct financial payment subsidies or specific government funding to or incentives for rural GPs. So why should we fill this gap? Why is it important? Filling the gap is really just one very small piece of information towards addressing the problem identified earlier, the lack of GP consultations in rural communities. So if we understand these characteristics, GPs will have an awareness of the scope of considerations when looking for a position. The information will assist practice managers and business owners to create attractive engagement packages and develop sustainable business models. It may assist communities to recruit GPs and hopefully governments in policy decision. In real terms, the information can be used for the improvement of the health of individuals, the health of communities, and also the sustainability of communities. Lack of access to GP services may result in individuals dying and in communities dying. The Medical Dean's 2023 paper, The Doctors Our Communities Need, focuses on building, sustaining and supporting the GP workforce. One recommendation is their call for innovative change to research and to build the evidence base for factors that influence GP career choices. My research project contributes to this bank of evidence. Now to the research question. What I really want to understand is, how do job characteristics influence GP's choice of rural practice? The sub-questions relate to characteristics interactions with each other and in different rural contexts. So think between MN3 and 5, or perhaps a rural coastal or a rural ranges or a rural inner west. So, and the last thing is the practical how and when of characteristics information. Now to the research. So I have two approaches. The first is an intricate review. So what's known about the influences on GP's choice of rural practice? And then a second study, which is some qualitative semi-structured interviews and focused group discussions. And this will be looking at the experiences and perceptions of the influence of job characteristics from the GPs themselves. So we'll just look at the study 1, which is the intricate review, and that's not quite finished yet, but I can give you some preliminary information. And my apologies in advance, this slide gets very busy very quickly. So the key messages of the papers fall into one or more of the WHO factors. A picture is beginning to emerge of what is known and not known about the influences on GP's choice of rural practice. Firstly, to the known. The family and community factor is popular in research, with discussion about childcare, schooling, spouse support, social networks, community expectation, and facilities. The career and education related factor, this highlights the value of specific rural training, the lack of links with colleagues, and the difficulty accessing education, noting that the difficulty is more about finding a locum GP than it is about the education actually being available. Papers looking at the personal factor consider rural life experiences, the impact of family ties, and individuals' values, and the consideration of altruism, and also that feeling of entrapment. The commentary relating to the mandatory service factor was quite low, and there was only one paper from the final review set describing strategies to address families living apart. Now to the factors of specific interest in my research. The two WHO factors which relate to job characteristics are working and living conditions and financial arrangements. The papers highlighting working and living conditions as an important influence on the choice of rural practice. Research comprehensively covers elements relating to the practice, including infrastructure characteristics and the team. The influential working environment elements include collegial support, independence, variety of patient presentation, and the scope of practice. Access to technology and referral centres are identified as important, but reference to the workload and stress elements appear in abundance in the papers. On-call, after hours, responsibility load, hospital work, locum doctor relief, long working hours, and burnout. Research into the financial aspects focused on level of remuneration and leave, with some analysis of the impact of incentives. So this exploration into job characteristics has provided a lot of learning. Firstly, the characteristic work agreements. There are only a few papers about agreements, and these focus on salaried positions and bonded arrangements, nothing about business ownership or contractual arrangements. The next characteristic, work responsibilities. Many papers show that these are really important in choice, particularly the on-call and working hours. And finally, work rewards. Consider that the rewards fall into two general areas, financial and non-financial. The papers show that money is just one reward, and yet the financial incentives appear to be a popular attraction strategy. And then, what is not known? The analysis to date has shown that there is minimal information about the interplay between the characteristics. For example, how responsibilities impact on agreements or how the rewards are determined. Then the second study. This study starts with interviews with GPs, and I'll be interviewing GPs, including GPs in training, who may be thinking about, currently in, or previously in rural practice, to take part in an interview and take part in an interview. Rural will be identified as MM3, 4 or 5. The research will be focused in New South Wales, as the state health systems tend to differ, and also on a really practical travel reason, I'm keen to do face-to-face interviews, as they, I'm sure, will be a much more effective communication and obtain some richer data. The practice managers and business owners will be gathered by Zoom, and I'm planning 3 focus groups with approximately 5 participants in each. So my last slide is to speak to the why. Like many PhDs, this research is personal. These photos are of the team at Lake Angelica Medical Centre in the mid-1980s. My then husband was the town's GP for 10 years. For much of that time, he was the only GP. The community relied on him to consult patients in his private practice, deliver babies, respond to farming accidents, care for inpatients, keep patients alive until the air ambulance arrived. Fingers crossed that the flares didn't fail on the runway those nights. And of course, all the paperwork. All this from the age of 29. This research is about helping rural communities to have equity of access to GP services. It is also about future rural GPs and their families. My hope is for the future rural GP to have strong collegial support, a life balance, and for opportunities for their family to know them. Thank you. So I'll stop sharing and we can just move to some questions and discussions. So that was a very quick overview, and my apologies for the difficulty with the technology at the beginning. I'm having just a quick look. Yes, that's absolutely right. Yes, GPs have several specialty training. Yes.
Oh, I wrote that, Anne, because there's a number of countries where the word GP is used to denote doctors with no specialist GP training, and family physician is used to denote the ones with the training. Though I've recently read quite a good WHO definition in one of their recent papers that actually gives the situation that a GP can be either.
Okay.
And I delight in standing up and saying I'm proud to be a GP, and I've probably got more postgraduate specialist training than many of the family physicians in the room.
Yes, and I guess certainly in the review of the intricate review, it was a bit of a challenge to just make sure that the people that were being interviewed for those research papers were actually equivalent to what the Australian GPs were.
Well, and then you've got the rural generalist term in this country as well, which you probably can't really ignore if you're going to do the research in New South Wales.
Yeah, so I'm hoping to interview rural generalists as well, because, as you say, you know, when in New South Wales we've got both of those classifications, if you like.
Yeah. But you're probably teaching the converted in Roger and I by talking about this, given it might have been more mysterious for Amber. Amber, who is Sayuri online?
Yes, she is. She's in Sri Lanka, and she said that she has some internet difficulties and some noise in the background. So she's one of our newer Rural Seeds ambassadors. So she's for 2024, 2026 from Sri Lanka.
Excellent. Well, if nothing else, it's given me another opportunity to talk about it. And I guess I'm really excited because I've just been starting to get GPs responding to my expression of interest, and so be starting in, well, I've done a couple of practice interviews, and so I'm looking forward to doing some real ones.
I think your research is very interesting, and certainly in the Virgin Islands, where I'm at the moment, our upper management and government are kind of in denial that we're anything related to rural. So all of the issues that you talked about, that the WHO have clearly defined, every time I talk to the current director of primary care about them, she's like, oh, we have this problem. I'm like, all rural areas have that problem. There's actually quite a significant body of research about the issues that we have. Like at the moment, we're having a lot of difficulty with remuneration for the on-calls in my hometown, because the family physicians in the capital, once they clock out at 4:30, they're done for the day. They don't have the same, they're on call, but they have the hospital. Whereas in my hometown on the weekend, our on-call is 48 hours. It starts Saturday morning and ends Monday morning, and we get paid the same. We don't get paid any extra for that. And then they don't know why they can't get any doctors over here.
Yes. Roger, do you have any hints or directions?
I'm not really sure where to start. I guess my first question to you is, what happened between when you showed the photograph and now that's sort of led you to, it sounds like you're just starting on a PhD. Is that correct?
So I started about 12 months ago. So what happened since then?
So what have you, yeah.
So you mean career-wise?
Well, anything. I mean, it's okay. You said your then husband was a GP in Lake Cargellico, and now you're doing this. There must have been something in between.
There's a lot in between. So we had 10 years there, and the marriage didn't extend after we left Lake Cargellico. And so
I'll put my fingers in my ears, and seeing I know your former husband.
That's all right. I mean, Peter's, as you can see, he was happy for me to use his photo. And the funny thing is that my husband now, sorry, I'll start from the beginning. So after Lake Cargellico, I came to Canberra and did a MBA, and basically developed my practice management consulting skills. So in most of my career since leaving Lake Cargellico has been as a in-house manager or a contractor or consultant. And I did have an academic position at UNE Partnerships, which is the vocational arm of the University of New England. I looked after the diploma of leadership. So I really spent some time there. And really most of my career has been doing consulting in general practice, some specialist practice as well, but mostly general practice. And then I had a couple of stints away from consulting. One was with General Practice and Education and Training, which is the training program for AGPT, and I was the quality manager for 4 years there. And so I had a lot to do with the regional training providers in assisting them to develop, you know, everything for their accreditation, and then I conducted the accreditation in collaboration with the colleges. And then just before I retired, I had a couple of years as the faculty manager for RACGP, New South Wales and ACT. And so that was an interesting time because I came into that role just in time for bushfires and floods and COVID. And so I finished up at the end of 2021. So I guess my interest in this, as I said, it's very personal. I mean, the 10 years that Peter and I had in Lake Jellicoe, it was, you know, he was on call virtually every day. And yeah, you know, I experienced it from the spouse's role, and that's it. Is that what you were asking, why I was actually doing it?
Yeah, something like that. I mean, my next question is, you used the word retirement, so I'm getting the impression that you sort of finished what you consider your work life, and it sounded like with the RACGP.
Yeah.
And now, is this a kind of, you know, retirement hobby, a PhD, or?
Oh,
or
no,
probably
no.
the bigger question is, after the PhD, what happens?
Yeah, after the PhD, well, I guess it will depend upon the results of my PhD. I mean, I have to get that, but I'm quite keen to be involved still in this area. And I guess I don't want other families to experience what I experienced as a rural spouse. I mean, there was lots of really positive things, but if I can contribute to, you know, I guess I'd like to stay in academia. And what that picture looks like, I don't know. But I just think that there's an opportunity to look at more the business side of things and have that straightened out. And as I said, it's only one small component in that big cog to the answer.
Interestingly, Roger, at the same time as Anne was in Lake Cargelligo, I was in Eugowra, another one doctor town in the sort of central west of New South Wales, and again with a rural spouse. And I felt quite strongly that having a male spouse as a woman was much harder for the man, even though he was actually a farmer. And because we went out to dinners, medico-legal dinners, and he would be sitting with all the wives and I would be sitting with all the doctors and lawyers. So I don't know why I keep going black and dark and light. Yeah.
Oh, well, Karen, I should confess to you, the holiday house we're staying in is Peter's.
The one you're staying in?
Yeah, because we're on. Yeah, no, we still see each other. It's lovely. We just took a different path.
So Peter's a tutor in the rural clinical school, Roger, of course, because anyone that has been out in that situation and been doing obstetrics for Peter's procedural would, and still doing obstetrics really, is a good person to have in the rural school.
He's passionate about the obstetrics.
Which one?
He loves it.
Which rural clinical school?
ANU.
Oh, the ANU one, okay.
Yeah. That's where I've retreated to after Alice Springs, Roger.
Oh, okay. Well, I mean, I would hope that rural clinical schools are not just, shall we say, places to retreat to for rural doctors who are kind of looking for somewhere to be sheltered, but Yeah. So, and just so you understand, I was the first professor of rural health in Australia and the head of what became the Monash University School of Rural Health,
Right.
which really provided the prototype for university departments of rural health and rural clinical schools in Australia. And then I left Australia really as all of that was, particularly the rural clinical schools were really sort of taking off. So I've kept in touch. I've actually been based here until the last month or so.
Mm.
And I'm interested in so you're talking about New South Wales. You said, well, New South Wales, all the states are different. They're also not, they're also changing. So for example, I was in a situation last year where I was visiting the Rural Doctors Network in New South Wales, and presumably you know them and you're
Yep.
connected with the
Yep.
work that RDN does.
Yep.
And they now deliberately have their office just across the railway line from the New South Wales Health.
Yes.
And so went over and met with some of the
Richard.
people at New South Wales Health, and talked about various issues, some of which were relevant to what you're talking about or connected to what you're talking about. And I didn't appreciate until the briefing afterwards how much the situation's changed in New South Wales. So RDN was established after the strike in 1987.
Yep. Rural doctor strike. I was in part of, around then.
What's that? Sorry?
I was around then.
Yeah, right. So, and that was primarily about those doctors serving the hospitals in New South Wales. You mentioned Peter was doing obstetrics and that sort of thing. So what I discovered last year was that the current bureaucrats in New South Wales Health, in their mind, hospital work is the responsibility of the states, and general practice, so out of hospital medical care, is the Commonwealth, and there's a sort of divide. So that's a big change from how New South Wales and Victoria and all the states except Queensland, were back then and have been over the decades. So I think that you talked about GP. Karen explained that in other countries the term general practice is used differently, and not consistently, as you found looking at the literature. But the sort of term in Australia is general practice. I'm trying to think of how I think it's interesting that you kind of anchored what you presented in those WHO documents from 2010 and 2021, both of which I was involved in writing.
Oh, wow.
But because I think that there's a tendency in so high-income countries like Australia to ignore the World Health Organization. That WHO is there really for low and middle-income countries. I see Amber smiling at that. Even though often the issues, the real issues are just as real and just as relevant in countries like Australia. So I don't know where you see that connection, where you see the interplay between community level care and hospital level care in those MM 3 to 5 communities. Maybe these are questions for you to have to ask when you're doing your interviews and the focus groups.
Yeah, and certainly, I think you're right. I think that's an important thing to look at, in that the doctors, GPs' responsibilities do change across the MMs, and I think the communities themselves are going to be different as well. So I think that what I may find when I'm talking to GPs about their responsibilities is that there's a differencing depending upon what the demands and the location of the community itself. So I guess what I'm thinking is, if somewhere like Tumut that has the big paper, the pulp mill, you know, where there's industry, but there's also rural. I mean, there's also farming. So that would have some specific responsibilities of the GP there.
Yeah.
Yeah.
Yeah. So I think, I mean, there are lots of sort of dynamics, shall we say, in this. This is different from the usual rural cafes, and I'll tell you, I attended many of them right back from the first one in 2015. In that, usually it's a kind of round table discussion of sharing experiences, rather than a formal presentation. And your presentation was all really about Australia and specifically New South Wales, as you acknowledged. So I guess the question is, what else is there that maybe wasn't that you need to be thinking about, and is in literature, and I can send you a whole lot of literature if you're interested.
Yes, that'd be great.
That really is exploring dimensions that aren't necessarily obvious from the way the chart that you presented, and the you know, the problem with that kind of analysis is that it tends to become very transactional. It's about, you know, this factor and that factor and how they interplay and so on. And the reality is that what makes general practice, particularly general practice, is it's about relationships. It's relational. What draws doctors into general practice is the patient-doctor relationship, and that. So, and then, you know, that reminds me of research that I did back in the early 1990s in Australia. The hot topic of the time was that should GPs be gatekeepers or resource managers in the system. And so we asked that question of GPs and of their patients, first in rural areas. And at the time, the GPs were, like me, looked after patients in hospital and provide a whole lot of hospital-based services, as well as in the community. And the patients really valued that and appreciated that. When we talked to their patients. And then we went into the urban areas and discovered that this was back in the early 1990s in Melbourne. The GPs then felt that they were sort of buffeted around by all kinds of forces that really put pressure on them to take almost a customer's always right response to their patients. So they saw, you know, about 24-hour clinics and alternative, you know, medicine and nursing departments, all this sort of competition. So what was interesting was that when we well, first of all, my co-investigator in the research was a psychologist who before this research had only ever interacted with GPs as a patient. And so as he was hearing them talking about how they didn't really feel they were in charge of anything, as in like a resource manager or gatekeeper, you know, the question was, well, why do you do it? And the answer was, it's the relationship with the patients, and that's so rewarding and satisfying. And then when we asked their patients, they didn't see that their doctors in the way the doctors saw themselves, in the sense that the patients by and large saw their GP as their personal medical advisor and expected the GP to say, no, you don't need that test, or, you know, not time for that specialist here. Let's, you know. But the doctors they felt under pressure to say yes when people came along and said, I want this test and I want that specialist and so on. So we're talking about 30 years ago, and in various ways, as the system and healthcare has developed, it's become more transactional rather than less. And you know, underneath it all, it's about people and relationships. And so, you know, as I was starting to think about this topic, why or not rural practice, it's about the people and relationships. So I think that's, you know, you need to bring that into the exploration, and not just ask the GPs and the managers, but ask the people in the communities, as we did. And there's, you know, a lot more research that's happened. Then I was part of a group around the Arctic Circle that developed the fancy name is the Remote Rural Workforce Stability Framework, but basically a framework for recruitment, retention of health and other public sector workers in remote rural communities. And one of the issues that became clear to us, so we were 5 countries, which were Norway, Sweden, Iceland, Scotland, and Canada. Very different systems, different languages, different everything. But we found we had more in common with each other from the remote rural communities across international borders than we had with the people in the big cities of our own country. And so that's another factor to be kind of exploring in your research. And I've already picked up on one, which is the mindset of government and the way that the governments now sort of subdivide. And Amber talked about, and I've heard her tell this story before about the mindset in the Virgin Islands amongst the administrators who, don't come to her island very often, except for holidays. So, there's I think these are issues that they're kind of in there in your framework, but they're not, shall we say, immediately evident.
No, that's good feedback. Thank you. Thank you very much. Great. Thank you.
If I can add on to a bit of what Roger is saying, even within Rural Seeds, a lot of our members, the reason why they get active in Rural Seeds or even show any interest in rural in the first place is because of a personal relationship with someone who was already in Rural Seeds. So that's, very telling about the importance of that personal connection, specifically in rural areas. A lot of the doctors who move to the Virgin Islands, yes, you show them how to do the job and how to do the clinical aspect of things, but they also need to be able to adjust and assimilate to living in a very small rural community. I had a conversation with our newest doctor recently, and she said she's just gotten used to the sensation of someone always watching her.
Yeah. Yep.
Because someone is always watching,
Yep. Yep. Yep.
Guys, I'm going to say goodbye.
Okay.
And thank you, Anne, for presenting it. I haven't seen it at the uni before. So,
okay. Thank you. Thanks, Karen.
Have a nice day, Amber, and good night, everyone else.
Thank you.
Thank
Bye.
you. Bye-bye.
Yeah, I've got to go as well.
We're coming up to the hour anyway.
Yeah. Good luck.
Roger, I think I saw your email somewhere. So do you mind if I just email you directly? And because I'd love to, any particular references would be great, but to be able to just sort of bounce some ideas off you later on, maybe.
Yeah, sure. I'd be happy to do that. Did you say you have my email, or do you want me to?
Yeah, I
give it to you
think.
now?
Well, if you can give it to me now, that'd be fantastic. Thank you.
Well, I can type it in the chat, or I can tell you what it is, or however you want it.
Oh, you can just tell me. I can write it straight down.
So it's Roger, Roger,
Yes.
Strasser, Strasser, well, you can see that written on the screen, at NOSM, which stands for Northern Ontario School of Medicine, NOSM.ca, Canada. So that's the email address I'm still using. And I'm still involved, although, I did 17 years as the founding dean at NOSM. But I'm still involved in various research projects and other activities of the school, as well as having been in New Zealand and having an academic appointment now and emeritus with University of Waikato in New Zealand. So still doing lots of stuff.
Thank you. Thank you so much. I really appreciate it. And thank you, Amber. Thank you for facilitating me getting here. And this just became out of a response to me wanting to attend one of the cafes that had some interest to me, and Amber organised a link. So thank you for that.
Yeah, my pleasure.
Okay. Thank you so much.